Great, thank you. Hello, Archana Patel. Thank you so much for offering this incredible opportunity for our Club Med virtual members. If you guys don't know already, my name is Mariana, and I am the event spokesperson for Club Med Virtual. I will be leading today's session, reading any comments posted in the chat, and facilitating the conversation as we go along. Before we start, I want to remind everyone to please maintain proper etiquette and keep yourself on mute unless Archana specifies otherwise. If you have any questions, you can post them in the chat and we will address them as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance and will terminate at 30 minutes after the session is over. Please stay on the call for at least 5 minutes after the session is done to ensure that the survey is working for you. This session will also be recorded and posted on YouTube if you are unable to attend or want to revisit certain topics discussed today. But you cannot receive shadow or attendance hours if you are not present in this call and complete the survey. All right, so I'm going to turn the session over to you.
Okay. Hi guys, my name is Archana. I am a physician assistant in Hawaii. I have been a PA for about 2 years, and I actually have a PowerPoint. So let me pull that up and get started with the PowerPoint. Okay, everybody see this okay? Yeah, yes. No issues. Okay. All right, so let's send. Okay. So yeah, I'm an urgent care PA full-time, and I'm also a pre-PA mentor, as some of you guys may know from my Instagram. So a little bit about me. I grew up in Georgia. I am multilingual. I speak 3 languages. I have a bachelor's in biology from Armstrong Atlantic. It's a small school in Georgia, and I minored in Spanish. And then my pre-PA patient care experience was as a certified pharmacy tech. I worked at CVS. I didn't get into PA school my first year, so between my first and second time applying, I did a master's in biology at Purdue. And then while I was applying the year after that, I worked as a research assistant at Indiana University School of Medicine. So that was really cool because I worked as I learned 2 things. One, I learned, the impact of diabetes when it comes to wound healing, specifically with MRSA infections, and 2, that I never want to do research ever. And I got into PA school. I started in January of 2016. I went to South University in Tampa. They have several locations. I think they just opened. This is like their first class at the West Palm Beach location. So they're kind of all over the East Coast, I think. And during PA school, I was president of my PA school class. And that was really cool because I was involved with interviewing and reviewing CASPAs and personal statements. I did it all like for 2 years. So that was probably one of the most rewarding parts about PA school, to be completely honest. I mean, yes, being a PA, but also like kind of being on the other side of it and seeing what it's just everything kind of comes full circle, being on that side of it. So for you guys going into PA school, I highly, highly recommend getting involved with like your executive board of your class, because this seems to be a common thing where the exec board members are involved with interviews in some sort of capacity. Graduated in 2018. I've only ever practiced in Hawaii. So when I was in PA school, my husband was already in Hawaii doing his residency. He's a hospitalist. And so I moved here right after. My first job was locum tenens, is on a military base. So adult medicine, given that it's a military, it would be 18 and older. And the population was mostly male. A lot of orthopedics when it comes to military medicine, as you guys can imagine, with having to physically exert yourself. So that was good. It was a good first time experience. I learned a lot. I was pushed into like doing things on my own from the beginning versus see one, do one, teach one. But I do think that's what helped kind of break me out of my shell of, lack of confidence, because that's one thing when you get out of PA school, you're not super confident in your abilities despite passing the boards. Since then, I've worked in pediatrics and sleep medicine. I've done in my short PA career, I've done sleep medicine more than anything else. I did sleep for a year and a half. So that was really cool. I did CPAPs and BiPAPs. management of that. I did sleep consultations, so people who came in, because they couldn't sleep or had issues, and maybe the primary care or the psychiatrist tried to work up every other problem and then decided, okay, well, nothing else is working, so maybe let's revisit the sleep issue, and then they end up having sleep apnea, needs to be treated. That sleep apnea is the bread and butter of what I did. Currently working in urgent care. I do work there full time. I started this job back in June. I do a little bit of sleep medicine on the side still, but it's very, very little at a different sleep clinic on the island. I did become certified with the American Academy of Sleep Medicine. And so to keep the certification up and just to keep my knowledge of sleep medicine up, I wanted to at least have some sort of continuity there. AP to PAC, which is where many of you may know me from, is my new brainchild for this last year. I started it because one, COVID, that was the biggest thing, is the virtual shadowing. It's trickled down a little bit because I've just gotten so busy with work, but I do plan to pick back up on it. So I started it because so many shadowing opportunities were closed, right, in person because of COVID, and there's so many restrictions in place. So I offer free virtual shadowing. It used to be every week, but my goal with virtual shadowing is, one, to kind of normalize it. I do think it's different when you can't see, the provider and the patient in person. I understand that, but I also think that virtual shadowing allows you to have exposure to specialties that you may not otherwise have exposure to. For example, I have and so next week we have a stem cell transplant PA coming up. I had no idea that you could even practice in stem cell transplant. So you guys will be learning just as much as I'm learning next week. And then I had a colleague of mine who practices medicine in Southeast Asia. So she talked about international medicine and how it's different from what she did here, because she practiced in Florida for a year before going overseas. And so those are opportunities you don't get in person. And that's kind of my thing for why I think virtual shadowing should be more widely accepted, even past COVID. Pre-PA mentoring service. I do it all. I have mentees. I do limit how many mentees I take every cycle. But basically it's beginning to end. Like, I'm working with you. I'm creating a timeline for you where, okay, by this date, you need to give me your personal statement. Okay, by this date, you need to get me your second and final revision of the personal statement for me to review. Your resume, your CASPA experiences. There's now a COVID essay on CASPA. That's also a part of it. Mock interviews a part of it. Private consultations, we do 2 of them. And then I also review supplemental applications for a couple of schools of your choice. So it's an overall thing. But this is also because I realized that so many people don't have guidance when it comes to applying to PA school. And I didn't when I was applying years ago, but I thought there was definitely, there's more out there now. And I think just increasing the opportunity to be able to work with somebody who's gone through it, I think is huge. And not everybody needs it. I mean, if you grew up in a family of PAs, you don't need a mentor, but if this is you, just shoot me an email and we can figure out if it would be a good match for you to get additional guidance there. All right, so pharmacy tech. So for any of you guys that are kind of far from your PA journey and don't have like a patient care experience job yet, just a little bit more about what I did as a pharm tech. So filled patient prescriptions as ordered by the provider, of course, and under the pharmacist supervision. You educate the patients on programs available for medication maintenance. So discount programs, things like that. Communicate with insurance companies for patient drug coverage. Educate patients on the uses and indications of medications. That's within your scope of practice. You do learn a lot as a pharmacy tech about meds and indications and how they work in the body. You learn medication indications, brands, generic, and dosages. And then, of course, you gain exposure to part of the patient care experience. So you learn about what happens after they see their provider. So for me, I was missing that before part, like what went into the medical decision-making process that led to the patient needing this medication and being under our care at the pharmacy. So my why did I go into medicine? So I had a cousin who had a brain tumor. He was very, very sick. And when he was sick, I always I just didn't understand why. I didn't understand why he kept coming in and out of surgery, why he was on and off from the, why he was coming on and off the ventilator all the time, why he was breaking out on his face as a reaction to medications. There was so much that I didn't understand. And so It was after he got sick with his tumor that I went into, decided that I would go into medicine. And then when I was going into medicine, so my cousin was in pharmacy school when he was sick. And so I decided I would become a pharmacy tech and kind of follow in his footsteps. And like I talked about my pharmacy tech experience, I got the second half of the story, but I didn't really get the first half of the story for the patient. So to me, I needed a more overall picture where I could be more involved with medical decision making and go from start to finish. So I knew being a pharmacist wasn't going to be for me. And then I ended up with appendicitis. So I went to the ER. I was cared for by a PA. And this is probably so many people have experiences like this, but it was the first time I saw a PA, and I thought it was really cool that he was a family medicine PA, and he was working in the ER like 3 or 4 days a month, just to basically for his skills, like his minor procedure skills, draining abscesses, removing moles, ripping off toenails and suturing, things like that. So for why I chose the PA path, I decided from there that I was going to become a PA, but I wanted to shadow and learn more, right? So I shadowed an orthopedic PA and a cardiothoracic PA, and both of those PAs, they were both trained the same way. They're both generalists, but both of them had very, very different scopes of practice. And that's what I thought was so cool, is that neither one of them had any more training than they did in PA school, but she is the surgeon's right hand and constantly is in surgery and in the hospital. And he is also in a surgical specialty, but didn't really go to surgery because his physician had a residence. And he also spent a lot more time with the supervising, or a lot less time with the supervising doc than she did. And so I thought that was really cool because it's the same career and just two very, very different paths. So I ultimately decided to go to the PA path because of the versatility, and I like the idea of being autonomous, but having this balance of collaboration with the supervising physician. And then we talked about why I created the platform. So things I learned as a second time applicant. It's a marathon, not a sprint. You can't compare yourself to others because everybody does have their own path. Online forums, they're informative, but they can also shake your confidence. Some of you guys might have dealt with this in the past or are dealing with it now with college admissions or whatnot. And you have to start preparing ahead of time. And this is why I do this like strict timeline with my students, because I want to make sure that you're preparing ahead and everything should be done by March. Like, even though CASPA doesn't open until the end of April, you don't want to be in the third week of April still finishing your personal statement, because you are going to be stressed out, and then everything just kind of spirals from there. It doesn't matter how many times you apply, just make the small sacrifice, long-term goal. Apply early. You guys, if you guys have been to my virtual shadowing, you know how much I emphasize this. You have to apply early. Applications open in April. You should submit by May if you can. Submit as early as possible. Interviews are a major success. I don't think we give each other enough credit for getting interviews, because to give you like an idea of numbers, when I applied to PA school, my program got 1,200 applicants that year, and then they interviewed 200 of us. That's huge, right? 1,200 to 200, and then within the 200 that interviewed, they accepted 24. My class had 24, so it's about a 10% acceptance rate, and even less, right, from the overall application pool. So getting the interview is huge, and then of course, like, wait lists. It's not the end, right? People come off the wait list all the time. Mike, my good friend from PA school, who I did the EKG class with, Mike was a second time applicant, almost did not get in. He was on the wait list. They called him the day before orientation, and he moved that same day from Gainesville. So luckily he was close enough to Tampa to move to Tampa. Oh gosh, sorry guys. Luckily he was close enough to move. But yeah, so what was I going to say? Rejections. So brush them off, learn and grow from them. It's hard. I've been there. Like, I know how much it sucks, but you just learn and grow from it. You're not going to just not become a PA because you get rejected once. And maybe that wasn't the school for you anyway. So just come back stronger the next year. And then of course, an acceptance, best case scenario, just take your time to relax because PA school owns you for 2 years. You literally do not have a life outside of school on most days. My program, like my classmates and I definitely made it a point to have a life outside of school, but yeah, definitely you do feel some restraints with PA school. All right, what is a physician assistant? Most of us know, but just to make sure. So this is a very common interview question. Advanced practice provider, we get patient history, perform physical exams, order and interpret labs and imaging, formulate treatment plans, and prescribe medication. We do perform minor outpatient procedures and are usually first assist in the operating room. So like in an urgent care setting, I would perform like abscess strains, things like that. We're trained as generalists, so we treat from pediatric to geriatric populations. We are versatile because you can get up and practice in any specialty. And then we do have a balance of autonomy and collaboration with the supervising physician. PAs are also bridging healthcare gaps between medically underserved and quality medical care, which further reduces the healthcare cost in the country when you have a physician assistant filling that gap. What does an urgent care PA do? So urgent care PAs do have a broad scope of practice. You can basically, any specialty is going to come in, right? I've diagnosed from like basic ear infections to, of course, like heart attacks, to fixing lacerations from an injury, to like catching like really bad fractures, to having like diagnosed cancer. So I mean, you really literally see everything. Is everything urgent care appropriate? Not necessarily, but patients don't know that. They don't all know what's appropriate for an urgent care and what's not, right? I mean, you shouldn't be diagnosing cancer in an urgent care, right? Idea in a perfect world, but it's not the population. So no 2 days are the exact same. Some days are slower and less stressful. Some days are really busy and more stressful. Sometimes the busier days are the really simple, like every other person has an earache and they're not stressful at all. They're just busy. And then you address any patient presentations that come through. We do COVID testing. So we do work school travel testing. And then we also do symptomatic COVID patients. So I do work with COVID patients. I get I mean, it's trickled down a lot in Hawaii, but I did get, I would say, probably a couple a week in the beginning. And some of them, like that's in addition to like work, travel, or school clearance patients who come in, no symptoms. They just need to get clearance to go to their job or travel or whatever, and they end up testing positive. So those are the ones that we're always worried about, right? The asymptomatic carriers. So we do see those too. We can start IVs, we drain abscesses, repair lacerations, whether it's stitches or staples. Usually in the head, we do staples, and any other minor procedures like removing toenails, things like that. Workers' compensation cases, my least favorite part about urgent care is workers' comp. There's just a lot of paperwork, and sometimes these cases drag on for months and months and months. So if I had it my way, I would not do work comp at all. Medication refills, we do for bridge therapy only, again, misuse of an urgent care, right? I mean, you shouldn't come to an urgent care to get a medication refilled ideally, but sometimes there's different circumstances. If you're traveling and your primary care is at home and you lost your meds or airline lost your luggage and you don't have your medications, okay, yeah, that's legitimate. I don't always ask why they need a refill, but sometimes I will, I generally won't do like psych medications, just because there's more that goes into that. Pain meds too. I usually don't do pain medications. And bridge therapy means just that, like you're just giving them enough to get to their primary care or whoever the prescribing doc is. So usually I'll do like 5 to 7 days. Max would be 2 weeks for like high blood pressure or high cholesterol medicine or whatever that may be. And then of course, patient education, you're always educating patients. That's like, no matter what specialty you're in, you're going to be educating patients. So case study.
Before we get to that, so sorry, we have some questions in the chat
Oh,
and
sure.
make sure we get to some of these.
Mhm.
So Christina asked, I've heard the PA field is becoming saturated, meaning that there's a lot of PAs out there and it is difficult to find a job as a recent graduate. Have you noticed that?
Yeah, so I dealt with that myself. So when I moved to Hawaii, I got my job finally. Well, one, I couldn't take my boards until June, which the rest of my class had pretty much taken their boards in like April. And that was just availability. But then, yeah, I didn't start my job until October. So I was out for 7 months when I first graduated. It's hit or miss because the rest of my class, everybody had jobs. And I had offers from Florida because that's where I did the bulk of my rotations, but I wasn't going to be living in Florida. So there's a lot of factors that can influence that. It's definitely becoming saturated, given how popular the profession's becoming. But I also think there's so many healthcare needs in this country. I mean, if you look up PA jobs and you have no boundaries or barriers, like no particular state or anything, and you're just looking nationally, there's tons and tons of jobs out there. There's Facebook groups for PA jobs too, and I see postings every day. So there are jobs out there. For new grads in general, it's hard as it is. I mean, that's just being a new grad in anything. I mean, for physicians, like my husband, when he graduated, because you have to go through the residency and the match process, there's going to be a job there if you match, right? Even that's not guaranteed. So if you match, there's a job waiting for you and they're taking you as a new grad because there's a structured training program. So for you, I would say, like, if you graduate PA school and you want to go into a field that is highly competitive, so urgent care as a new grad, emergency medicine, surgery, ortho, like those are competitive fields. Derm is super competitive even as a physician. If you're going into those competitive fields, consider, and you see yourself in them long term, consider doing a residency. Residencies for PAs are becoming more popular. They're certainly not required, but if you see yourself in that field long term, I do think it's worth doing a residency. Is it worth doing it if you're not going to be in it for a while? Probably not, because you aren't going to be paid like a PA and you're going to be working way more than you would normally be working. But maybe that residency is what you need to get the competitive edge to try to get the job. Nothing's going to guarantee it, but maybe. The other thing to consider would be when you're in school during your clinical year, to make sure you do really well in your rotations, especially the rotation that you see yourself practicing in, and could be a potential job, right? Like all of my job offers were through my rotations. They came from people that I rotated with. So I mean, that happens a lot, and that's actually pretty common. That's why most of my class had jobs when we got out of school, because we were offered during our rotations. I also had my PA school classmates, a couple of them they had moved from like another city in Florida, and they worked as like patient care techs in the ER, or like one of my friends, Adam, he worked as a patient care tech in the emergency room before PA school, but he had worked there for 2.5 years. So the docs knew him, the PAs knew him, everybody knew him. So they told him, like, when you come back, you're going to have a job waiting for you. So he had a job as a new grad and nobody questioned it. He didn't need anything, but he's always been in the emergency room. So there's circumstances like that too. So it's all about networking and then doing your best when you're on your rotations.
Thank you for that. So I'm just going to ask one more question from the chat. For those of you who posted other questions, I'll try and get to those in the Q&A session. But Faja, I'm so sorry if I mispronounced your name. They asked, what do the admissions committees look for in the personal statement?
So it's your story, right? The personal statement is supposed to answer why PA. That's what it's supposed to answer. So I did a webinar on this a couple weeks ago, and I will be doing another one. So just look out for it. It'll be free. But basically, the personal statement needs to answer your why PA. They're not asking why not MD, why not NP. They're asking why PA. So like I gave you guys my why. I gave you kind of the story and the thought process behind like what got me into medicine. Okay, now I'm thinking about medicine. So what path do I want to take? I don't know. I mean, let's just, maybe I started working as a pharmacy tech, right? And then I'm still trying to figure out what path to take. And then I had a personal experience with my appendicitis where I ended up meeting a PA. But so for you, it might be another reason, some other reason you ended up on PA. I've read so many different stories about how people ended up on PAs, or even medicine. Some people went on a mission trip with school, and they realized there that they wanted to become a PA because of just seeing other communities and underserved areas not having access to health. Everybody has a different reason, but the personal statement needs to bring that out, and then it needs to bring out why you would be a good fit, or not specifically for their program, but why you'd be a good fit for PA. Like what qualities do you possess that would make you a good PA? You should also address, like, if you have any sort of issues with your application, meaning you've failed courses or you had like a bad semester. I wouldn't address individual bad grades. I mean, there's not enough room for that. But if you had a bad semester, just explain it very briefly. It's not the focus of your personal statement, but you're owning up to it and you're addressing it. And hopefully, you addressing it in your personal statement would mean you're not going to be asked that offhand during an interview. Because the personal statement ultimately is what you want to tell the admissions committee about you and about why you want to become a PA on paper before they decide to meet you. So think of it like that. It's your only voice. Everything else is objective stuff, right? It's numbers and letters on CASPA. Everything else is. This is the one part that's you. This and your CASPA experience is like explaining what you learned as like if your patient care experience like an EMT or an MA, like what did you learn? What was your job description? That kind of thing. That's important too. Wording is everything for those also.
Yeah, thank you for that.
Any other questions?
I can ask the rest of them closer to the Q&A
Okay.
session.
Okay. Yeah, so this case study this won't take too long. So 28-year-old female comes into the urgent care clinic. This was about, now it's been, I don't know, maybe 2 months ago. She has abdominal pain and is concerned about a urinary tract infection. She's had UTIs before. So her vital signs, blood pressure 128/84, respiratory rate 18, pulse 16, temp 98, oxygen 98. Last menstrual cycle, so this is more than 2 months ago. Last menstrual cycle was October 30th. So I think I saw her like 2 weeks after this. Her pain scale was 7 to 10 at 10 out of 10 pain, abdominal. Current medications, allergies, past medical history, and surgical history. Standard, this is all standard stuff that we get for every patient, right? So she only taken ibuprofen for the pain, no allergies, no past medical history, no surgical history. So history of present illness, HPI, this is the part that we type out. And basically it's what the patient tells me. It's subjective. So it's from the patient's perspective. And it's basically their symptoms and what brought them in. So she had a sudden onset of sharp cramping, abdominal, and pelvic pain, 7 out of 10 since 3 p.m. that same day. And I saw her, she came into the clinic around I think like 7-ish. So it was a few hours. Associated with nausea, vomiting, cramping, blood in the urine, pain when she urinates. And she's had spotting for 2 weeks since her period ended. Said that she's had spotting in the past. She had already talked to her OBGYN about this too, just being monitored. She had a really bad UTI in January of last year and was hospitalized. She said it feels the same. So that's already kind of triggering you, right? That UTIs, you don't become hospitalized from uncomplicated UTIs. So no new sexual partners, no chance of pregnancy. She wasn't on birth control, no history of STIs. And then she denied all of those symptoms. Dyspareunia means pain with intercourse. She wasn't having any. Flank pain is like right above the kidneys on the back. You would have that sometimes with kidney stones. Generally, you get flank pain. Fever and chills you can have with anything. Rigors. There's an infection called pyelonephritis, where it's like basically a UTI that ascends into the kidneys, and pyelo can cause pretty distinctive like fevers, chills, shakes, and flank pain. That's pretty classic for pyelonephritis and UTI symptoms. Okay, and then the physical exam, of course, is what you examine on the patient. So everything was fine, heart, lungs, skin was good. Abdominal pain, her bowel sounds sounded good. She didn't have any costovertebral angle tenderness. So that's tenderness in her flank area on the back, like basically over her kidney. She didn't have that. Generally, when you have that, you're thinking about kidney stones. He was severely tender in the right lower quadrant and pelvis. So, and she was guarding, meaning her arms were covering her right lower quadrant. She also, with the tenderness, she also was very tender with like a light touch. So it wasn't like you do light palpation in all the quadrants and then you go back and you do a deeper palpation. And sometimes patients can't feel the pain until you go in deeper. In her case, with the light, she was like coming off the table. It was very painful. Positive Robsing signs. So these signs that are listed here, these are all for appendicitis. And they were all positive. So of course, like you're thinking appendicitis, she did have an appendix, and it was in the right, your appendix is in your right lower quadrant. So if you look at your belly button, kind of diagonal down to the right from the belly button is where the appendix is. She did not want a vaginal exam done. And then psych stuff was all normal. So Robsing sign is when you palpate the left lower quadrant. So if you go diagonally down from the belly button on the left, when you palpate that, it causes pain on the right. That's Robsing sign. It's not normal. McBurney's point. So when you go from your belly button to your anterior pelvic bone, basically, 2/3 of the way down, and if you have pain there, that's basically where the appendix is, and that's McBurney's point tenderness. Like if they're tender there, that's a positive sign. Obturator sign, so you internally rotate the right thigh. So if they're laying down, take their foot, turn it internally rotate it, and that will cause pain in that right lower quadrant. And then psoas sign, I have the patient lie on their left-hand side, straighten their leg, and I just pull the right leg back, the right thigh, and that causes a lot of pain for appendicitis. So objective data, urinalysis and all that stuff. Okay, so what's important here? Blood, she had some blood, she had leukocytes, so white blood cells, but leukocytes are very little, plus minus, not much. Appearance was red cloudy, of course, because she had blood in the urine. I always run, so even though we asked her if she was pregnant, and even though her period was 2 weeks prior to that, and she was spotting, right? I always ask if there's any chance of pregnancy, because I mean, who says that a period was 2 weeks ago and you didn't have intercourse in your fertility window right after that, right? I mean, she wasn't planning on getting pregnant, but you never know. So even though she declined it, I did the urine HCG pregnancy test and she was positive. This is also important in general because you can't just put a patient of childbearing age on any antibiotic you want, especially if there's any chance that she's pregnant or if she is pregnant. There are some antibiotics you can't take during pregnancy. So in my opinion, it's still important to know. She ended up being pregnant. So now my differential, and then, so looking back at this urine, the blood you can have with urinary tract infections, you can have it with kidney stones. I mean, there's a lot of reasons you can have blood in the urine. But her pain was very, very out of proportion to just a UTI. Like I was no longer convinced after seeing this urine and seeing the pregnancy test that this was just a urinary tract infection. The reason is because now I know she's severely tender on the right side. She has blood, she's been spotting, and she has a positive pregnancy test. Do any of you guys have any guesses for what I might be thinking at this point?
So you guys can unmute yourself, but also Yasmin put in the chat miscarriage.
Okay, that's a good guess.
And then Jessica put ectopic pregnancy.
Okay, yeah, that's a good guess too. Okay, see the chat. Okay. Okay, so let's go forward. So most important decision, and this is kind of like the part of urgent care that's super, super stressful, is knowing, like, for patients like this, right? Can I send her home and just have her come back tomorrow and follow up? Or do I need to send her to the emergency room? That's what disposition means, is where does the patient need to go from here? Is the patient stable? She is. We went through her vital signs, nothing alarming about her vitals. She doesn't have low blood pressure, high heart rate, nothing like that. Her breathing's fine, oxygen's fine. What's the next step? So for her, it is emergency room, because yep, I was thinking my first thing was a ectopic pregnancy. Spotting, positive pregnancy, recent menstrual period, and intractable abdominal pain. However, we went through all of the appendicitis stuff too, because this is the thing with medicine. It's the good thing and it's the scary thing, is that, you know, in one area with all that pain being there, is it coming from an ovary? Is it coming from a pregnancy that shouldn't be there? Or is it coming from her appendix? In either case, in an urgent care setting, you're not going to figure that out, because the most I have with as far as imaging is concerned is an x-ray. We also don't run labs in our clinic. So we could draw her blood, but we don't run any lab tests like in the clinic. We send it out. So at what point do I need to decide this needs to be done now versus this can wait? And in her case, I thought she needed to go. So normal pregnancy, fertilized egg implants on the uterine wall, 300 million sperm enter vagina during intercourse, and they either flow out or they die because of the acidic environment. And then some sperm passes through the cervix into the uterus. So my mouse went out, but yeah, some sperm passes from the cervix into the uterus, and then the uterus destroys a lot of the sperm, considering the sperm as invaders. Half of the sperm travel to the fallopian tube with the unfertilized egg, and then a few dozen of the original sperm remain by the time they reach the egg, and then the sperm burrows into the egg. The first sperm to make contact will fertilize. In ectopic pregnancy, the fertilized egg implants somewhere else. The fallopian tube is the most common. So it could implant in the cervix, which is further out before it even gets to the uterus, the ovary, the fallopian tube, or the abdomen. The embryo develops and grows in areas that aren't meant to like strain or sustain. And usually this is detected during the first trimester. So you're not going to go very long before you realize that it's an ectopic pregnancy. And it can be life-threatening if it's undetected because of the tube bursting and internal bleeding, which is what I thought happened in her case. I thought she had a ruptured ectopic pregnancy because she was bleeding, right? An ectopic pregnancy alone would cause pain, but it wouldn't necessarily cause the bleeding. But when you're at a point of your spotting, yeah, I'm thinking that your tube is burst. So what happened to my patient? Ultrasound, they didn't see any intrauterine pregnancy. That's another sign because ultrasound, they're looking at the uterus. They didn't see any pregnancy in the uterus, but she has a positive pregnancy test. That's right there is an ectopic. Then next they do a CT scan. They found hemiperitoneum, meaning there was blood in her peritoneal cavity, but her appendix was normal. So she had all those positive appendix signs, but it wasn't the appendix. There was also a 2-point decrease in hemoglobin, meaning she's losing blood and she is hemorrhaging, but clearly her blood pressure wasn't low. So maybe it just happened. Maybe she wasn't spotting as much, and maybe the spotting was worse that day. Clearly, she wasn't the best historian because she also said there was no chance of pregnancy. So exploratory laparoscopy is the next step because they couldn't determine the source of the bleeding. So they confirmed that it was a ruptured ectopic pregnancy. Her right fallopian tube had burst, and that was what was causing the bleeding. So they took out her tube as a life-saving measure. So that was the same night she had surgery. She was discharged 12 hours later after being observed, and she followed up outpatient with an OBGYN. The products of conception, meaning the other tissue and whatnot, they'll continue to shed for some time. She came to the clinic 5 days after her procedure, and she was extremely grateful for the care that she received. Okay, so surgery, ectopic pregnancy rupture, and so these would be indications for why you'd get surgery. Rupture, of course, of the pregnancy, hemodynamic instability, meaning you've lost too much blood, intraperitoneal bleeding, which she also had. Non-surgical options, methotrexate is also used to end pregnancies. Non-surgical other options would be no intrauterine pregnancy, confirmed or suspected ectopic pregnancy, and abdominal pain, severe or persistent abdominal pain. Any questions?
All right, so I'm going to start reading some of the old ones that we had in the chat, but if you guys have a question, you can also raise your hand or mute yourself, and you can interrupt me because don't feel bad about it, because I'll just keep reading the questions that we have here. So someone, I think it was Chris and Aaliyah, wanted to know more about what it was like being a PA on a military base.
It was good. It's very different because on the military base, you're not seeing any kids for one. I see a decent amount of kids in urgent care. That's probably the first thing. And then the second thing would be that you have medics in the military that also do everything for you. So like these medics are trained to treat patients on the front lines. And so they know how to put in chest tubes, they know how to intubate, they know how to do a lot of stuff. And so that's another thing that kind of separates what I do now versus the military. I do think it gave me a really good experience. I do think that it helped me with kind of learning, definitely learning independent practice, because in the state of Hawaii, every state's different, but in the state of Hawaii, your supervising physician can be a phone call away. They don't have to physically be there. So I learned a lot about like just making decisions on my own. And that was exciting and it was scary at the same time. But I do think there was a lot of military support, and I was so thankful for my medics. Like being new, it was really important to me to have people that were very strong, like staff that was also very, very strong and good at what they did, and medics know what they're doing. So it was a very good experience. Yeah. I will say, like, you see a lot of the same stuff though, at least in the clinic I was in. Like I saw a lot of ortho, like musculoskeletal stuff, and that's just obvious because they're always exerting their bodies, right? So whether it's training like PT or whatever it may be. So in that sense, I didn't get a broad spectrum of things. Like I never saw chest pain, you know, nobody ever came in for chest pain there. I never saw shortness of breath, like difficulty breathing. I don't think I even fixed like a laceration when I was there. I might have removed one toenail, maybe. So yeah, not a lot of variety, but good experience for sure.
Thank you for that. We also had a question. I know you talked a little bit about this subject, but some of our members are wondering what the autonomy is like for PAs.
Yeah, so the autonomy is it's driven by the state. So every physician, as it's physician assistant, as it stands right now, every PA has to have a supervising physician. But whether your supervising doc needs to be in the clinic with you, or can be a phone call away, or needs to be within a certain radius of the clinic, is dependent on state laws. For me, my supervising doc, I've never practiced with another physician. So I've never had a physician come into a patient room with me, and I've never had to like call my physician to report every patient to them. And contrasting that, I don't know what the laws are in the state of Pennsylvania, but my PA school roommate practiced there, and when she practiced there, her doc was seeing patients after her every time. Every single patient her doc would come after and see the same patients. So, you know, I mean, that's also something that's different. You know, I mean, I don't know what the laws were, but her doc was seeing everybody after her and signing off on all her charts, and that it's just that's never been the case for me. So.
Yeah, we also had a question regarding the difference between emergency medicine and urgent care.
Urgent care is between family medicine and it's between family medicine and the ER. We're like a step in between. Emergency medicine is the ultimate. So in an urgent care, so family medicine is like maintenance medicine, right? Like routine stuff, diabetes, high blood pressure, high cholesterol, things like that. And then you have urgent care, which is, okay, my family doctor can't see me, but my ear just started to hurt today and I can't get an appointment with them. That's urgent care. Emergent from that is I evaluate them in an urgent care and their eardrum is ruptured and it's like actively bleeding. That's now emergent care. That's beyond what I can do for them in an urgent care. Urgent care will typically have like, we can usually draw blood. Some urgent cares do run their own labs and blood in the clinic. Our clinics do not. Some do though. So we send them out. We draw the blood there, but we send the tubes out there. The lab guys come and pick it up. And then some urgent care. It's like we have x-ray in our clinic. So I do x-ray. I recently got an x-ray tech, which I'm so excited about. So I don't have to like shoot x-rays most days, which is nice because I had to learn how to do that. PA school doesn't teach you how to shoot x-rays. We learn how to interpret them, but not actually like working the x-ray machine. My supervising doc taught me that when I went to urgent care. So that was really cool too. What else do we, it's very like basic stuff. Like if we, so I've had some lacerations that I can't repair in the clinic. They're just too deep. I send them to the ER. Like they check in, we evaluate them. I don't know until I actually evaluate, right? So I evaluate them and I say, okay, this is beyond what I can do for you. You need to go. Chest pains, of course, if the EKG is concerning, call an ambulance and send them to the ER. So we're a step up from family medicine, but we are not primary care providers. So that's one thing that I think patients like, it's two, I mean, there's two types of patients. There's the ones that because of COVID, they can't ever reach their doc, you know, and so they come into urgent care. And then the ones that are like, even when COVID's not there, they treat us like we're primary care. So like, you know, I mean, nothing to do about it. You have to treat everybody that comes in, but I definitely like, I will give them the same speech like every time they come in, you know, there's a, you know, just FYI, like we're not primary care. We don't run routine labs. Like I don't check thyroid function, you know, like things like that. So yeah, a lot of it's patient education.
Yeah, thank you for that. So we actually have a question from Christina. She said, I'm interested in dermatology. Would I have to do a residency or that? Okay, sorry. I think I'm like reading it funny, but is that an option?
So I don't know if there's even any derm residencies out there right now. The ones I know of, there's like one cardiology residency. I think there's one out there. Derm. I don't think there's any derm ones out there. Emergency medicine, there's tons of them out there. Derm is just a hard field to get into, but it is very PA saturated. So, you know, this is a time where when you're choosing your rotations in PA school and you get like an elective rotation, meaning like one you get to choose by yourself, pick derm, you know, and just make sure like you study and your work and you really impress them. And then if your program allows you to apply to, or if your program allows you to have like a second elective, like my sister's PA program allowed her to have 3 electives. And so when she had 3 electives, like you could do like 2 out of 3 could be derm, or all 3 of them could be with the derm, you know, the same office or a different office or whatever. And you should always treat an elective as like a trial like job, right? You should work just as hard as you would if you were working there, because that's the only way you're going to know like the real lifestyle and what the work life is. I can't, I think you're muted.
Oh, sorry for that.
Yeah.
So Prince was actually wondering more about how you went through the process of concluding that it was an ectopic pregnancy.
Um, yeah, so pretty much the stuff that I mentioned with like it's like a combination of everything. So like, you know, severe abdominal pain, her urinalysis, like the urine is kind of her pain is out of proportion to what the urine's showing. It's barely showing any white blood cells at all. She has blood, which I knew because she told me she was bleeding. Um, she also had a positive pregnancy test. So spotting plus a positive pregnancy test plus severe abdominal pain as an ectopic pregnancy is just one of those things you learn in school. Just like you would learn that chest pain that radiates down the arm is a heart attack, most likely, right? Similar to that. So it's just a pattern that you learn. Have I ever seen an ectopic pregnancy before this? No. Did I review it right before this? No. So it's one of those things that like you think you don't remember and then it happens and you're like, oh my God, this is like literally textbook. And yeah, it has to be this, you know? And you never know. I mean, when I sent her to the ER, I didn't know. I mean, one of the things I was thinking was, you know, appendicitis, ectopic pregnancy, ovarian cyst also. Some ovarian cysts can be very painful, cysts that are on the ovaries. And when they burst, you can have bleeding, right? So, I mean, but without imaging and doing like ultrasound or CT abdomen and all of that stuff, we don't know. And we just don't have that stuff in urgent care.
So we have a question from Jason. What pre-PA healthcare experience did you notice was common? Scribing, medical assistant, EMT tech.
Mm, okay, so scribing, I really like scribing personally. I wasn't a scribe. My sister was a scribe. I think you guys learn, like scribes learn a lot. Um, because you're in the room with the physician or the provider, and you're learning to recognize disease patterns because some stuff you just see all the time. You're the one documenting it, so you are actively having to pay attention. And so I think scribing is good patient care experience. However, a lot of PA programs don't accept scribing, and I don't know why it's not considered patient care experience. But medical assistant is more, I guess medical assistant is more direct than scribing, but MAs, medical assistant is very, very good. I would also say EMT is very good also. You're very hands-on with both of those. So I guess, yeah, I could see why, but I do think scribing is a good experience. You know, you just don't physically put your hands on the patient. I think it's a big difference. So I would say MA or EMT.
Yeah, thank you for that. So we do have a couple more questions, and I'll
Mhm.
try and get to those. I actually have a question though, since my mom is interested in PA. How would I don't know if you've seen non-traditional students like reviewed their applications, but how would someone talk about some experiences that they've had that might have affected their pathway? Because I know for my mom, it was having kids.
Yeah, I mean, there's so many different experiences can affect that. I'm working with a student now who, um, she has been an OT for a long, long time, and now she's going to PA school. It's just a career change for her. I worked with another student last year who she had gone through all this like personal stuff, and she was busy with like raising her kids and stuff, and so her career was on the back burner. She's in the military, so there's so many different reasons, but, the thing that a non-traditional, meaning just like an older applicant with other life experiences has that new grads coming straight out of undergrad don't have is just that. It's life experiences. It's the things that make you mature. It's the things that drive a good work ethic, right? We've seen like great undergrad. We've seen great students coming straight from undergrad who are great, and then we've also seen ones that are maybe the maturity factor is lacking a little bit or something like that. So everybody has there's a strength to being a non-traditional applicant and starting PA school at a weird time. But I would say like anybody who's non-traditional should talk about the experiences, talk about what brought them to PA and why like the experiences they've been through would make them a good PA, because those are experiences that nobody else is going to have. So that's what I would say. They would need to get some patient care experience if they could. That's something that they would still need to do. And then, of course, like making sure that your undergrad, like pre PA, like prerequisites are all within, the time frame that the school specifies and stuff like that.
Yeah, thank you. So I'm only going to read off two more questions before we end the
Okay.
recording. But Arcana, I don't know if you would be able to stay after for a little bit because I know we still have people like flooding questions in the chat.
Yeah.
All right. So, Preddy, I'm so sorry if I mispronounce your name. You can absolutely yell at me after if I do. But they asked, how can I apply my major public health to PA?
Health major to PA. It's just that's based on what made you get into health, right? Did you get into health just to get like a general understanding? What was it about health that made you interested? And then health is such a broad term, right? And it's such a broad major too. So even then, like, how'd you end up on PA versus MD, NP, DO? um, for PA school, you can have any major you want. So it doesn't matter what your major is. You just have to make sure you finish those prereq classes. But yeah, I mean, how is health applicable to PA? Only you can answer that. Like what about your health major convinced you to go into PA? There must have been something that triggered that interest. And so it's just bringing that interest into it.
So Albano asked, are PA programs more lenient during COVID, GPA and patient care? I'm guessing you could probably throw shadowing in there as well.
Yeah, I don't know. I do have my students reach out to the programs for this reason because I don't know if they're more lenient, but I do feel like some programs are open to virtual shadowing. It just depends on what the shadowing is, which is why it's so important to make sure you word everything well on CASPA with the experiences. But are they more lenient? If a GPA for a program is a 3.5 and you have a solid like 3.0, that's a reach school, whether it's COVID or not. I mean, they still have that GPA. And if it's still, assuming the website's been updated during, sometime during COVID, if that's still the GPA, I mean, they still have this, requirement. So knowing like what programs you should or shouldn't apply to and like realistically applying is also a big part of it because that can save you a lot of money. If you're ever questioning, like, if you had a hard time finding in-person shadowing hours and you wanted to shadow, or but you have tons of virtual shadowing hours from being in quarantine, whatever it may be, email the school. always email the school, because ultimately I can say whatever I want, or another pre-PA mentor can say whatever they want, but ultimately the school is making that decision, right? As far as whether they're going to accept your experience or not, or if they're going to, give a little bit of slack on your GRE scores or your GPA or not.
All right, thank you so much. So I'm going to give the closing statement, but if you are able to say after, like, you don't feel any pressure to, because I know you PAs and all the medical professionals we have on here have a busy schedule.
So I'm doing a talk actually. I have to just get on a phone call after this, but I am doing a talk with the PA platform. I'm actually doing a question and answer session with the PA platform at 8:30 Eastern time. So if you guys wanted to, it's Q&A. You can submit your question and answers to, like, message them to Savannah on the PA platform, and then we're just gonna basically go through questions and answers that you guys have. So you guys are welcome to attend that. That's tonight.
If you have a link for that and you could post
It's
it.
on Instagram. The PA platform is the page. It's here. I can put it in the chat. The name of the that's Savannah's page, and then the PAC. The link is in her bio. You do have to register, so just make sure you register for the link for the event. It's in her bio, not in mine. But it is just a Q&A session, so I will probably cover whatever questions that you guys have.
All right, well, thank you so much for that. And thank you so much for this incredible and insightful session. I think we all learned a lot today. And I hope to have a session with you again in the future. If you'd like to post social media handles or links to your business endeavors in the chat, you can feel free to do so. And to our WSU students, please make sure to fill out the Google survey that was posted in the Zoom chat summarizing this session to obtain your shadow hours. So thank you all, and I hope you have a great night.